Hello, everyone. I'm Ron Rolfing, and I'm the Preferred Vendor Coordinator here at ACAP. And I'd like to welcome you to our latest ACAP Vendor Education Series webinar presented by ACAP Strategic Ally Pop Healthcare. Our presenters today are Arturo Diaz, Chief Operations Officer of Risk Adjustment Operations, and Carrie Harnish, Executive Director of Community Connect. And they will be presenting the webinar, Leveraging In-Home Assessments to Understand and Address Social Determinants of Health. But before I turn it over, I do have a few housekeeping items I need to take care of. This call, along with all ACAP calls and webinars, will be held in accordance to the ACAP antitrust guidelines. And these guidelines can be viewed on our website. We will be recording today's webinar, and we will post the slide deck and recording on our website by tomorrow morning. And the link to these items can be found in the invitation sent to you for this webinar. And please remember, if your plan is looking for a vendor, be sure to check out our list of preferred vendors on our website. Just look to the top of our homepage and click on the preferred vendors link. And of course, during the call, you can ask a question at any time. You can do this by clicking on the Q&A icon at the bottom of your Zoom window and typing in your question. And all questions will be answered at the end of the presentation. Now, I'll pass it over to Arturo and Carrie.
Thank you, Ron. Thank you very much for the introduction. Hi, my name is Art Diaz, and I'm joined with Carrie. And I'd like to also thank ACAP for allowing us this opportunity. Pop Healthcare has a long history serving ACAP health plans and their ACA, Medicaid, and Medicare Advantage members. We appreciate the opportunity today to share with you some of our experiences with the in-home assessments and SDOH. We have been providing in-home care at Pop Healthcare for many years, and SDOH is something that we've been tracking during those years. We tracked it even before it was called SDOH. Many times we just called it poverty. You know, we've been to members' homes, and we know your members and their challenges. So what Carrie and I have prepared today is information which we hope will be valuable to you. We hope that it will be engaging to show you how we reached out to your members, worked with your members, documented their SDOH struggles, and most importantly, how we connected them to resources to assist these vulnerable populations. And often these are services that are underutilized. So we have found that our in-home assessment programs are a conduit to connect needy individuals to available resources. All right, Carrie, we can go on to the next slide here. Thank you. So just a little bit about Carrie and myself. I am the COO of Pop Healthcare's Risk Adjustment Operations. My professional background includes leading risk adjustment programs for a number of Blues plans and national medical groups. And it is my honor to co-present today with Carrie Harnish. Carrie is Pop Healthcare's SDOH Solutions Leader. Carrie is a licensed master social worker and the executive director of Community Connect, which is Pop Healthcare's SDOH solution. Now, Carrie's vision ensures that all of Pop Healthcare's clinical products include an integrated SDOH assessment, as well as offering a standalone SDOH solutions product, which Carrie will discuss later in her presentation. Carrie partners with our clients to address their SDOH needs and populations and creates the change within their social and healthcare systems in order to remedy those that have, as Carrie puts it, those other things that deeply impact the lives of our neighbors. Okay, Carrie, let's go on to the next slide, please. So for today's discussion, we prepared topics regarding an overview of Pop Healthcare and IMCARA. IMCARA is the branding for our clinical services. And we'll go over our experience to establish our understanding of the terminology, which we'll discuss today, followed by the results from 2021 calendar year experience, and concluding with why this matters to your organization and to your community. We very much view the members as a community. Once we conclude our prepared slides, we really look forward to your questions during the Q&A session. Carrie and I are eager to hear your thoughts and suggestions, whereas we understand that together we can address the important and large needs within our community. Carrie, next slide. So this is an overview of Pop Healthcare's service area. We have 22 clients across 17 states. We are closer to 800 employees now. We actually have an office in Manila too, where we do a lot of our medical record coding. That's not on the map. We support Medicare Advantage plans, ACA plans, managed Medicaid lines of business, and we have a growing practice with the at-risk provider groups as well. Within the medical provider organization, we take a full integrated approach to delivering care. That means whether it is the once a year visit in the members' homes, managing high-risk members in their home for a longer period, or taking full risk as the primary care provider for members. Pop Healthcare is one of those rare companies that offers a gamut of services. We were founded in 2006, and since our beginning 15 years ago, we've evolved from helping health plans operate their risk adjustment programs, including the calculating the risk scores and forecasting their payment impact, and submitting their encounter data to CMS, to launching the in-home assessment program in 2014, followed by the further launch of the CareSide program. And then finally in 2021, we were excited to launch our home-based advanced primary care. But throughout this history of Pop Healthcare, over our 15 years, our mission has remained quite simply to lead the effort to reimagine how healthcare is delivered, improving the lives of those most in need every way we can. And we believe that if we can continue to stay focused on the lives of those that are in most need, we will lead this change and be recognized as America's leading national medical group in providing in-home and virtual care for our vulnerable seniors and adults. With over 22 clients in 17 states, Pop Healthcare does offer that unique integrated approach that I discussed earlier in not only care delivery and risk adjustment solutions, but also quality enhancements, serving the highest risk populations with unwavering commitment and dedication. Carrie, you can go on to the next slide, please. And this is an overview of our full solutions of Pop Healthcare. And you can see that we've divided up into two major divisions. One is the risk adjustment area. When you see the risk adjustment area, I'd like to first of all emphasize that these solutions that you'll see, risk adjustment and MCARA, which represents our brand for the care solutions, are applied to the ACA populations, the managed Medicaid populations, and the Medicare Advantage populations. If we start off on the risk adjustment services, I'd like to point out our risk adjustment advisory services, which is one of our oldest lines of business and currently one of the most frequently requested lines of business with many of the new entrants into the provider space. Many of these new provider groups need assistance in setting up their risk adjustment programs since they've taken risk or have a value-based contract. Our services include developing their market-leading risk adjustment operations program through our own experience. We also offer risk adjustment expertise on the regulations and assist with even the benefit and bid designs for these programs. We also offer, if you continue going down the thread, you'll see that we include an HCC quality gap targeting analysis. I'd like to begin to say Pop Healthcare, since its inception, has made the mastery of health data a primary focus. Our core expertise in understanding claims data, normalizing, optimizing, and analyzing available data to really ensure that we have a broad picture of the experience for our clients. We use these data to identify the greatest opportunities, whether it's understanding their population to assist with bid designs, to understand data leakage, whereas we often think here at Pop Healthcare, data as currency. Data lost might mean revenue lost. And we also provide chart targeting, in-home assessment targeting, as well as identifying those patients with advanced primary care needs that we recommend either long-term support or other assignments into environments that really deliver the care and quality that these patients may need. These are all done and driven through our analytics engine, which are provided through this target and prioritization. We have a full suite of HCC reporting or hierarchy reporting to understand the risk adjustment programs for our clients to give meaningful insights identifying areas that need their attention. Essentially, timely, actionable, valid reports is really the mantra that we render our HCC reporting. We conduct chart reviews. We do both onshore and offshore chart reviews. We have over 90% acquisition rate of the records with the ability to directly connect to EMRs, quickly download large data sets, and then send them off for coding for quick turnaround. We also work with clients to submit their data, whether it's the RAPS, EDPS, EDGE data submissions to CMS or payment calculations. On the care side, we see that we have the in-home assessments. Those include the targeting, and we will go into more detail about the in-home assessment program, but those are generally the annual assessments, the comprehensive assessments that are done at a member's homes, which include point of care testing, as well as the documentation that's submitted to CMS for risk adjustment score purposes. We also have the advanced primary care. There's essentially two versions of the advanced primary care. There is the identification of members who have chronic needs, but we'll partner with the member's care team and deliver care in the member's home. The fuller version of our advanced primary care is MCARA clinicians taking full responsibility for these members. We will serve as their primary care provider. Carrie, next slide, please. So some quick definitions here on the in-home assessment. Most of us are familiar with these in-home assessments. Sometimes they're called health risk assessments. They're done in the members' homes. I'd like to point out that we do deliver both the in-person modality and the telehealth modality. We've been offering telehealth actually before the pandemic started. Telehealth has been one of our modalities to manage and connect with our members for many years. So expanding and pivoting on our established telehealth technology to do in-home assessments was relatively simple. We have found that our telehealth encounters deliver comparable value to the in-person assessments. It's a valuable solution when members do not want someone in their home, but still need a comprehensive assessments, including a medical and SDOH review. Telehealth has delivered for us. Our telehealth options also include the ability for us to complete a real-time visit when we contact a member. If the member is unwilling to have someone come to their home, but they are willing to do a telehealth visit and they want to do it now, we have clinicians available to render that visit at that point in time. If a member does not have the device, the connectivity to do a telehealth visit, often they don't have broadband availability, we can send a device to the member's home with broadband ability to complete telehealth visits. The telehealth, the typical visits, whether it's telehealth or in person, take about the same time, 45 minutes. And our members often describe the encounter with our clinicians as one of the most comprehensive exams they've ever had. And our current Net Promoter Score for our in-home and telehealth visits is 72, which when you look at Net Promoter Scores and NPS, a 72 rating is on par with Costco and Nordstrom. So we're very proud that our members, our patients, are satisfied with their visits. During the visits, we look at their health history, we conduct physicals, we assess their behavior and psychological status, including PHQ-9 assessments. We also look at substance use disorders, alcohol use disorders, cognitive impairment. We are able to do point of care labs and testing when we do the assessments in person. We provide immunizations as well when we do the assessments in person. But also, and this is something that Carrie will emphasize, or Carrie and I will both emphasize, it is the education that we provide to the patients during the assessment that we find is very valuable. The education will be often connecting members with identified needs to appropriate assistance, whether it is clinical assistance through care management or triaging to other available clinical services, or connecting the members with available SDOH support. Next slide, please. So if we can go through the life cycle of the in-home assessment program. We start off with the identification of those members most in need. Here's where we rely on our data scientists and our data algorithms to identify those patients who will likely have gaps, and gaps that will not be filled during the current year. We often refresh our data analytics throughout the year when, as we get closer to the end of the year, those members that we thought had a somewhat likelihood of completing the gap through a member visit and still have not, those members then will be targeted at a higher priority. So we refresh and update our targeting gap analysis throughout the year. Our engagement is actually something that we think is critical to the program success. How we engage and prepare the member for our outreach. We do not believe in cold calling members alone. We send members information through the mail in distinctive envelopes that grab the member's attention. We also prepare our health plan partners and, if possible, the primary care providers of the program, so that if a member does call the health plan or the provider or health plan would say, yes, this is a legitimate program. It's not a scam. It's important that you do please participate and schedule your visit. Our outreach includes texting, emails, postcards, as well as mailing in distinctive envelopes. Once we schedule the appointment, we send reminder notices. And for those members who requested a telehealth visit, we do a dry run before the visit, a day before the visit. One of our technicians calls the member, verifies that they have all of the connections required to complete a telehealth visit. And if so, we're ready for the next day. If we identify issues, if it's an issue that requires us to send a device out, we reschedule the telehealth visit, allowing for sufficient time for the device to arrive to the member's home. And then before their scheduled visit, we assist the member with their new device to go through a telehealth visit. The visit itself, as I said, takes about 45 minutes, both whether it's in person or done through telehealth. We have a comprehensive visit, both medical, mental, and the SDOH assessment is conducted. There's often a question of how do you do an SDOH assessment over the phone? Well, actually through a smartphone. So there's an active synchronous audio and video. We ask the members questions, we do interviews, we spend time, we listen to the results, we look at the member and see how they respond to our questions, their probing questions. And then we also ask the member to flip the phone around, if that's what they're using, to show us their surroundings. So we're pretty confident we're doing an effective SDOH review through telehealth, as well as we would in person. Our documentation, we do our own documentation. We include the coding of SDOH, which has been a guided review during the visit. By that, I mean our EMR is set up to guide the clinician not only to address standard medical questions, but also SDOH conditions. Those responses are captured by our documentation. We send the encounter to our payer partners with the appropriate Z codes that have been identified. And then we proceed to follow up with the PCP and health plan with any risks that were identified during the visit. We also make sure that we make any referrals based off these assessments to community resources that are available. We verify that any needed follow-up is the patient is connected to their provider, and we verify that the information obtained during the assessment is provided to the health plan as well. It's important for us to make sure that the information is shared and made actionable as needed. So this is the overview of our in-home assessment program. I'd like to thank you for the opportunity, really just to lay the groundwork of how we are engaging the members, how we are assessing the members, and reporting the information back to our health plans. One of the things that we have been doing at Pop Healthcare is capturing these E codes and making sure we have the information available so that CMS can start building their own knowledge of the Medicare Advantage members or the ACA members and their SDOH needs. There was a presentation yesterday by CMS, and one of the presenters, and the presentation was about health equity. And one of the presenters said something wonderful that I'm never going to forget. She said, measure what you treasure. And we really treasure our patients and their needs that they often find themselves in, the challenges. So by measuring their challenges with SDOH conditions, we really hope that we can turn this information into actionable plans. So with that, let me turn it over to the presenter of action, Carrie. Next slide is yours, please.
Thank you, Art. I love that, to measure what you treasure. I've been on a kick of patient-centered care. So I think that's very similar to that of you're treasuring your patients too along with it. So by now, I am sure that you have heard social determinants of health a billion times. But when we make social determinants of health a clinical intervention, sometimes we forget that broader influence much beyond our patients and our clinicians' control. In addition to the social determinants of health listed on the slide on the side there, we should make sure that we are considering income and wealth, we're considering social status, employment at work, education, neighborhood quality, public policy. Those are factors at that community level, right? But as a clinician, this boat has sailed. These folks have already fallen into the river well before we see them. And yet I believe that it is imperative as clinicians to gather that data that can be utilized for systems change to really improve those community conditions, to prevent that health-related conditions later on, to keep them from falling in the river, right? But once you're face-to-face with a patient, you really do need to consider not only their individual factors, such as physical activity, diet, nutrition, tobacco use, alcohol consumption, but also those factors that are related to family and friends, neighborhood and community factors, and societal factors. You got to look at somebody as a whole person. Utilizing a social determinant of health assessment tool really does provide you with that whole person-centered care perspective, and enables that whole person care, which allows you to really effectively address that other 20% of the clinical care, the stuff downstream that we're looking at that we face every single day. If you have unstable housing, the last thing on your mind is taking your insulin on time, or how do you even store it, or quitting smoking. There are so many more pressing, where am I going to sleep? What am I going to eat? Am I safe? There are so many other pressing needs for that patient than their A1C numbers. So you got to make sure that you're being able to see that whole person, the whole reality. And so earlier I mentioned the systems change aspect of our work. I also want to give a plug for those community organizations, those fantastic folks that we make referrals to out there that have been significantly underfunded for all of these years, and the importance that we just don't continue that disparity. That just like we pay for equipment and testing and clinical services, we need to pay for those clinical or for those social services. Our referrals should really come with a payment. And so when you're thinking about program design for your social determinants of the health program, please consider that in your program design. Our next slide is talking about, over the last 2 years, we have completed over 40,000 social determinant of health assessments in our social determinant of health intervention alone. 5 counties, Southeast Michigan, we've talked to over, some of these are duplicates, but we've completed 40,000 folks. And these 5 things have remained the same. It's actually kind of surprising to me that as a social worker, that transportation, housing, financial support aren't in this list. It truly demonstrates the need for simple mental health intervention for loneliness, depression, and stress that we're lacking. We didn't ask about, do you have anxiety? We didn't ask if you had schizophrenia. We didn't ask for that stuff. We asked, are you lonely? And it was the number one answer, the number one group were depression, and loneliness, and stress. We also need an additional support for exercise and eating fruits and veggies. It's also highlighting the need we have for caregivers, which we know is only increasing as our population ages. It has really been fascinating to hear from our members on how much they appreciate that we're checking on them and considering them as a whole person. It's been pretty awesome to be able to send some of the recordings that our members have been calling us back and giving us feedback, and then also listening to the feedback that the members are giving on the plan and how much they appreciate that personal touch that we're doing for them. This is an example of the social determinant of health screens we utilize within our EHRs. Our screens allow us to trigger team responses to specific answers for individualized follow-up. And we also, like Art said, we share these ICD-10 codes with our clients to include in on the encounter. Our social determinant of health intervention uses a full accountable health community survey with a couple of additional data points that align with other plan priorities. And we've moved from simply asking the questions to standard and individualized response to the need. So if somebody says, yes, I have food insecurity, or well, they're not saying, yes, I have food insecurity. They're saying, yes, I worry about my food. And then we have specific customizable interventions for them, the resources that are based on where they live. And to Art's point about CMS, CMS is actually considering 2 quality measures related to social risk screening as part of this year's 44 new measures under considerations list. And those 2 measures are the driver of health screening rate, so the percent of beneficiaries 18 years and older that have been screened for food insecurity, housing instability, transportation problems, utility help needs, and interpersonal safety. And then you also have the second one is the driver of the health system positive rate, the number of beneficiaries 18 and older who screen positive. So how many did you screen and how many screen positive? So we are on the cutting edge of this one. So there's limited evidence. It's getting better. Yeah, I think all of us understand the social determinants of health really drive, health. But there's a lot of, they're still working on the evidence of that. But we know that health disparities and social barriers are recognized as a significant contributor to poor health outcomes. We know this, but we really don't know what that specific individual member needs. And our data has shown that SDOH needs actually exist in communities that are not identified traditionally by data sets as underserved. We often train our teams to look for those who are house rich, but cash poor. They're in those communities that they've got these big giant houses, but there's so much money that's gone into the mortgage, they don't have any cash left over, or that it's been paid off for so many years and they don't have cash left over. Food insecurity, transportation, loneliness can occur in most affluent communities. And you don't know until you ask each individual. And the interesting thing about the work that we're doing is that we're targeting everybody, everyone who has the plan. We are asking them these questions and we're able to recognize those needs before they start triggering all your clinical metrics that are saying, oh my goodness, it's costing us a lot, the claims metrics. We are able to identify those folks well before they're starting to hit your books. Identifying and integrating the closure of social determinants of health really does have the potential to help differentiate you and accentuate the value of your products to your clients and your members. So hold on, did want to talk. The food insecurity, transportation needs, and community safety needs, you can identify these are things that are going to eventually hit your books. So you want to identify those early, address those. And those are systemic needs that you can actually address too. You can start transportation programs. You can send food baskets to folks. We had some really great experience with the clinic or the COVID boxes. Those were very well received. And the food boxes are too. So some of the key elements of our success is who we hire. We hire our teams from local communities, the neighbor to neighbor, peer to peer model. My weather looks exactly the same as my members' weather. There is a significant difference in that conversation when they know that you're a neighbor, you're close by. And there's even a bigger difference when we are able to do in-home assessments. We're currently doing it telephonically, thanks to this neat little virus or the COVID thing that's gone around. But when we are face-to-face with our members, there's a difference in that conversation between when I'm sitting in the doctor's office and I'm sitting on the table, I got that paper gown wrapped around me and the doctor's like, oh, how much do you exercise? My answer is always like, oh, every day. But when the neighbor comes over and we're sitting on the couch and she's like, oh, how much are you exercising? You look at the treadmill. yeah, girl, I haven't been on that treadmill in 5 years. There's a difference in that honesty. There's a difference in that conversation that you have when it's face to face, when it's somebody that you're familiar with, you trust. That's from your neighborhood. Our models are also allowing us to really provide that warm handoff, identifying them early, providing that warm handoff to the next level of care. Perhaps it's a community health worker to help them through all of the different barriers that they have. Maybe it's an in-home assessment to make sure that they get all of that coordinated care. Perhaps it's the in-home care coordination pieces of it, or even the in-home primary care team. Building that trust early on, having those warm handoffs are key to those relationships. So when you're asking the questions, make sure that you have the information to do something about the answer. If one of our members triggers a need, we have a database in the background that has resources specific to that member. We also know when to connect that member to a more substantial resource, such as an area agency on aging or 211, folks that can address a big, wide variety of needs. Data, 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 data. Be data-driven. We measure and evaluate everything. How can you know you're making a difference? And in the end, that's what it's all about, isn't it? Making a difference for that one. All right. Questions?
Okay, our first question. If a plan hasn't yet begun a program where social determinants of health are addressed as part of the IHA follow-up, where do you recommend we begin?
So Karen, I think I'll take this question. The first thing I would say is let's take a look at the benefits that have been submitted in the plan. When I reviewed the 2022 Medicare Advantage benefits, I saw that meal benefit was available in like 67%. It was a really high number, maybe 70%. So even though it's a temporary limited benefit, if you identify a member with a need, let's send our clinicians out when they're doing an IHA to quickly say, I understand that you're having some trouble or you're not feeling comfortable with your food. That there are days that you don't have food. Here, your health plan has this benefit available. Let me show you how you can access it. Transportation is another common benefit as well. I think maybe 40% of the MA plans have transportation. The special need plans, the dual SNP plans, probably closer to over 80%, more than double of those plans have transportation. But again, it's the importance of educating your IHA partner on the benefits that are already filed in the plan. And then working with your IHA vendor, your partner, the clinician, as they're educating the patient. So as they're saying to their patient, you have diabetes, and it's important that you monitor your feet. It's important that you have your eyes examined. It's important that you take your insulin. You also follow up with say, it's important that you eat properly. Think of food as medicine. And this is how your health plan can assist you. Health plans and Medicare Advantage plans are getting more sophisticated in the social support available. They have these benefits that sometimes are specific to individuals identified with a specific need, like diabetes or congestive heart failure, where the available support is augmented for those specific cohorts. We just need to get the patients connected to the available resources. So I think about the what's called the special supplemental benefits for the chronically ill, SSBCI. If that's something that the plans are available or offered, let's have our clinicians educated and have education material available to drop off with the members identified in need. Okay, Ron, I think hopefully I didn't babble too much and I answered the question.
Okay, our next question. How do you collect social determinant of health conditions during a telehealth visit?
We ask questions.
Yep.
You ask them and they'll share with you. It's been fascinating that some of our team members, which questions actually kind of bother them And they're like, oh, somebody's not going to want to answer the question about the alcohol. And you're like, yeah, amazingly enough, folks are like, go right through it. So you ask.
Okay, straightforward enough. Getting members connected to resources is one part of the equation. What are some best practices for ensuring that follow through, both from the member and the referral resource occurs?
So we make sure that we keep things simple. We don't give half a dozen resources. If somebody needs a half a dozen resources, we connect them with the organizations that are specifically designed to help with those. So like an area agency on aging or 211, we keep things simple so that folks can actually, take one step and do the least frustrating way. We do a lot of relationship building, networking, purchasing the services, and remembering that we help our members to be able to understand that the clinical languages are spoken are different than social service languages. So having that understanding of when you ask for help as to what the difference is when you're asking for help from a social service agency versus from a doctor. And so we also make sure that we are speaking the different language when we're asking for that follow through and that follow up with us. And it's a lot about partnership. How do we close that loop?
Okay, our next question. Are you using a specific tool like Prepare?
We are using the Accountable Health Communities questionnaire with a few modifications.
Which we've also integrated into our EMR.
Yeah.
So that's the same, similar to what our clinicians use.
Okay. Can Medicare Advantage plans design benefits around social determinant of health conditions?
Did I just lose Ron? Oh, I'm sorry. Go ahead, Art.
Yeah, sure. Well, I'll start, Carrie, then I'll turn it over to you. The actual identification of, let's say, an SDOH at this point, not one of the categories that would say this is the benefit that we'll design. It works the other way around. So if you have a specific condition, and it could be mental health, whether it is a mental health condition or something like diabetes or coronary vascular conditions, then you can support and add required SDOH remedies. So the SDOH need itself does not necessarily drive more supplemental benefits. Rather, the condition itself, a condition could be, again, mental health, could be depression. As Carrie was pointing out, we identified there's a lot of loneliness. And if that loneliness does diagnose with depression, we can then at that point design a specific benefit that augments remedies to engage the individual with depression. And I saw, when we looked at the supplemental benefits that were available that were filed for the 2022 calendar year, social needs such as connecting people with community resources, senior centers, church groups, that was only available and it was less than 10% in SNPs. So of all the special need plans, 10% offered any sort of social support, but like 80% offered transportation. So we really need to get better at supporting individuals when we identify them as being lonely and depressed. As Carrie's data is showing, that really is the issue that we've identified now in our communities. Carrie?
I missed the question because Ron kind of cut out on me.
Okay. All right, Ron, next question.
Okay, our next question. What type of training do you recommend for clinicians conducting IHAs to uncover SDOH related factors during the IHA process?
What Pop Healthcare does is we have training available, a training academy for our clinicians, and they include topics such as managing specific prevalent conditions such as diabetes or cardiovascular. We also provide extensive training on the risk adjustment models. There's different models, Ron. There's the Medicare model, there's the Health and Human Services model that's used for the ACA population, and there's also various Medicaid models. Some Medicaid models also include SDOH. So all of that information is provided to our clinicians, and they are also provided routine updates too on education. So we want to make sure that our clinicians are kept current. We also train our coders. Coders are given extensive training on SDOH as well to make sure that they're capturing all the available Z codes. Then we do quality assurance reviews, both for the clinicians and the coders. And if we see that there are conditions that are not being addressed, we then follow up and provide one-on-one training for either the clinician or the coder, wherever we identify the need. Carrie, how do you train your social workers?
So our community health advisors are trained to understand their personal connections to social determinants of health and to really bring the passion of why they're there. And so that you can hear that through their voices when they're working with our members. We also teach them a lot on empathy, listening, and communication skills. So they're important when somebody is sharing some of those really close social determinant of health issues that are really uncomfortable for folks.
That's a great point, the listening. We hear back from our patients. They really appreciate the fact that we spend time with them. We're not rushed to get through this assessment, and training our clinicians to listen is where we gather a lot of this information that then we document. And as we said, we measure it so that it can become actionable at some time in the future.
Hey, our next question. Do SDOH conditions risk adjust?
Not in Medicare or ACA at this time. CMS, as Carrie pointed out, are looking at 2 quality measures for social screening. This is part of 44, I think, new measures. It's measurements under consideration. The memo came out like December 1st. The first measure that they're considering is a driver for health screening rate, and the second one is a driver for health screening positive rate. None of those will be part of or being proposed as part of the Medicare Advantage or ACA model at this time. But the fact that CMS is now making that pivot and including SDOH quality also suggests that they are collecting enough data, and when they have critical mass of data, they'll be able to determine what is the health benefit or the impact of SDOH challenge on healthcare cost. And Carrie mentioned some studies. There's been studies in JAMA. McKinsey has done a meta-analysis of gathering all the published data and has demonstrated that SDOH needs are correlated with higher healthcare costs, more ER visits, more inpatient admissions. So there's definitely a strong indication that there is a there. We just need to get enough data to CMS so that they can start developing the regression model.
Okay, well, that looks like it takes care of our questions for today. With that, I'd like to thank the attendees for taking time out of their day to join us. And I'd like to thank Carrie and Art for a very informative webinar. So please take care out there and stay safe. Thanks a lot.
Thank you all.
Thank you.